All right. Hello, everyone. My name is Trevor Gawronski, one of our EMS captains here at UEMR. And today we're going to be going over shock, specific to us here at UTD. Just kind of introduction here, we'll be going over the anatomy and physiology of shock, some different types of bleeding we might encounter, stages of shock, types of shock, treatment, most importantly, identification, and then our role here as BLS providers at UTD. To start off with, the cardiovascular system, as we know, comprised arteries, veins, capillaries, with the heart at the center. Its main responsibility for our purposes is going to be transporting oxygen, nutrients to the cells, and removing carbon dioxide and waste products. So when we go into bleeding here, we have both external and internal types of bleeding. External, we need to do proper trauma assessments to make sure we're actually finding the bleeds. Whether it's hidden under clothing or stuff like that. Ideally, it's something that we can visibly recognize and make note of. But we again need to be able to identify different types of bleeding, whether it's arterial, capillary, venous. And then internal bleeding may or may not be visible upon assessment. There's not always going to be, an obvious bleed or an obvious bruise somewhere. And also this type can result from a wider variety of causes, whether that's traumatic injury, like a blood clotting disorder, fractures, etc. So kind of taking a focus on external bleeding, we should be familiar with most of this. We have arterial, which is bright red blood, like rhythmically spurting out of an artery. Venous is going to be a dark red color with a kind of a constant flow to it. Then capillary will also be dark red, but it'll be like oozing slowly out of a wound. Treatment possibilities kind of depends on the situation. Maybe, it's an arterial bleed and we just have to put direct pressure with our hand, with the glove on, of course, until we can get something better on it. We could use, like a dressing, a pressure dressing, something like that. Or if it's on an extremity, we could use a tourniquet if we think that would be necessary. When we look at internal bleeding, we have some different signs and symptoms, including like anxiety, restlessness, irritability, again, the cooling clammy skin, tachycardia, hypotension. But then here we have to look a little more towards our scene or, medical history clues, whether they have blood in the stool, dark vomit, stuff like that. Abnormal abdominal findings, anything like swelling or tenderness. And pretty much we need to be able to consider the mechanism of injury and kind of think to ourselves whether or not internal bleeding would be likely, possible, things like that. So when we talk about shock, it's hypoperfusion. Essentially, it's inadequate perfusion causing inadequate oxygen delivery to the tissues. Essentially meaning that the tissues, organs, etc., aren't getting enough oxygen to them. And there are a couple things that we need to consider when it comes to the causes. Could it be a heart problem, which is a pump problem, meaning the heart isn't pumping out enough blood, or there's some kind of trouble with the heart that's not getting enough blood out to the rest of the body? Is it a pipe problem with the blood vessels? Maybe there's some kind of traumatic injury or something that is preventing it from reaching where it needs to go or spilling out somewhere. And then we've got a blood or a volume problem, which means maybe they've been bleeding for a while and, there's not enough blood to get the oxygen where it needs to go. So that's the last kind. Moving forward to stages of shock, we've got compensated, decompensated, and irreversible. Usually we want to be finding these patients in compensated shock. By the time they're reaching decompensated, we kind of are at our last chance to kind of recognize it, and then by the time they reach irreversible, obviously, there's no coming back from there. So compensated shock, the body is being faced with the problem, but it's able to kind of respond to it appropriately. We'll notice that the pulse is increasing in strength and rate. The skin becomes pale and clammy, and the patient may be anxious, restless, just seem a little off. In decompensated shock, the body responses are failing. We may not be able to palpate a radial pulse if the BP is low enough. At this point, you'll have the noticeable drop in blood pressure, the respirations are going to slow down, and you might have a further decline in mental status. And just, more so than like our anxious and restless, it might be, noticeable altered mental status. And then irreversible shock, essentially we have a complete lack of circulation, oxygen isn't getting where it needs to go, cells are dying, the organs are not functioning as they should, and that's going to lead to patient death. All right, now with the types of shock, we should be pretty familiar with these from EMT school or our own experiences. Let's kind of brush up on some special considerations for each one. Hypovolemic is the most familiar to us all, I would think. It's essentially a loss of blood or plasma volume. Traumatic injuries, burns are kind of the go-to answers for what's causing these. But we also need to think about vomiting, diarrhea, anything internally that would lead to a fluid problem. So some considerations for this: think about the mechanism of injury or the nature of illness. Consider whether or not it could be causing shock. Think about a medical history concerning fluid loss with the vomiting, diarrhea, as we mentioned. And then also, as with most of these, we'll be looking for diaphoresis, pale skin, cool and clammy. Distributive shock is broken down into a couple of different categories, the first of which is septic. It's essentially the body's response to bacteria in the blood, and the vessels are going to dilate and leak in response. So we might have a warm skin, fever, and then a recent medical history. Essentially, they've been sick a few days, anything like that, that would kind of be a red flag in your assessment. The other type of distributive shock is anaphylactic, which is essentially a severe allergic reaction. And again, the body's response is to dilate the blood vessels. We should be pretty familiar with anaphylaxis with the sudden onset of symptoms, itching, rash, hives, general edema, airway compromise. But again, this is a type of shock if it gets bad enough. Cardiogenic is a pump failure of the heart. When we think back to earlier, if it was a pump problem, pipe problem, or fluid problem, this would be a pump problem. We have the heart's like not contracting fast enough, not contracting to get enough blood out. Usually this is resulting from either an MI or some sort of arrhythmia, some sort of cardiac condition. So if we have a patient with chest pain, weak or irregular pulse, cardiac history, takes blood pressure medications, all those would be kind of things that would stand out to you. Again, we'd probably want to check lung sounds on this patient as well, just to see if there's anything affecting the respiratory tract. For obstructive, this is secondary to some sort of obstructive condition. Some we should be familiar with: pneumothorax, tamponade, or a PE. Again, this is secondary to those problems, shock secondary to those problems. So if we have any findings related to any of these conditions, we've essentially identified they may have one of these three, then we should be looking for accompanying shock symptoms to see if they are present. And so neurogenic, probably the rarest, I would think, but still something to look out for. It's from like a spinal cord injury. We've got, an interruption in the neurological system, and the vessels below the injury are going to dilate, which is kind of the common theme for all these, is vessel dilation. So consider your mechanism of injury, any sort of blunt trauma, major trauma, things like that. Are we having cool and clammy skin above the injury, warm and dry skin below the injury? That'll kind of be an obvious indicator. You have kind of two different situations above and below where you think an injury might be. And then obviously we'll be checking PMS to see if there's any sort of irregularities, whether it's in the upper extremities, lower extremities, both, or what have you. So for treatment, as BLS providers, we really are going to be focusing on assessing for shock, identifying shock, and then passing it on to ALS providers, would be more of our role. And our focus will be mostly maintaining ABCs. We want to rule out anaphylactic shock. We want to maintain an airway. We'll kind of assess their breathing and ventilation and decide if we should be giving oxygen, maybe ventilating for the patient, and then circulation, obviously, if they've got some sort of major bleed or some bleed that we can deal with externally. We'll take a look at that as well. So as kind of mentioned, our main job, our main responsibility is to understand the signs, symptoms, and stages. When we go to a call, we should be thinking about the MOI or NOI and kind of thinking to ourselves whether or not it would be possible to cause shock and kind of consider everything in the big picture to think if shock could be here. Anytime we suspect it, we need to activate RFD and provide, appropriate information about what we found out and why we suspect shock to the paramedics once they arrive. So case study 1, we have a cyclist into a pedestrian, just a bicycle into a pedestrian. The cyclist appears fine, doesn't want to be assessed. We probably won't worry about him at first. And then the other person who was hit by the bicycle is a male on the ground but conscious and breathing. And so how should we start our assessment? We'll probably think about, just go through the basics, C-spine ABCs, and then after that we'll move into a little bit more of a trauma focus and make sure he doesn't have any sort of major injuries, because this is a traumatic injury. So C-spine, patient tells you doesn't have any pain in his neck or back, and you essentially go through all the steps to clear it. ABCs, no major life threats, they're unremarkable. The patient seems a little shaken up. He might be nervous or a little jittery, but he is able to answer your questions. We do our trauma assessment. We find some minor cuts and scrapes, the arms and the legs. Not really anything to worry about. We examine the abdomen. We got tenderness with a small bruise starting to develop. And then we pull his pant leg up. We find some bleeding to the knee, continuously bleeding, but not like a major life threat. And then we take some vital signs. We have got, as presented here, the heart rate obviously is a bit high, respiratory rate is a bit high, and the blood pressure is more or less looking pretty average here. And he's oxygenating well enough, it would seem. So what do we think so far? There doesn't appear to be any immediate direct threats to life. Do we think this is a shock patient? Well, there are a couple of things standing out to us here that will identify the heart rate's high, respiratory is high. The BP doesn't seem to be too concerning, and the patient is, just a little, not necessarily disoriented, but a little nervous and agitated. So where do we want to direct our assessment? We'll probably finish out with, medical history, reassessing vital signs and mental status, and we'll see what we get from there. The vital signs pretty much in the same range. Nothing really gets any better or worse. So far, no pertinent medical history. The patient is, as we mentioned, fidgety and distressed throughout the assessment. And as you get deeper into the assessment, he can still answer your A&O questions. He's still A&O ×4, but he starts repeating his questions to you, repeating his thoughts, and kind of displaying a bit of, he's not entirely, he is A&O ×4, but he's not entirely sure about his mental status. So now is this a shock patient? I would say yes, and the clues that we need to look at, again, the BP is normal, but that should not be an indicator. This guy is probably in compensated shock still, with a high heart rate, high respiratory rate. He's been nervous and agitated throughout the assessment, and he can still answer questions, but he's starting to go towards a decline in mental status. And so all this should be indicators to us that this guy's probably in compensated shock. We saw earlier he's got tenderness of the abdomen, a small bruise developing, possibly some sort of internal bleeding going on. The MOI makes sense. He had a blunt trauma, and it's definitely possible that he's got some sort of injuries. So this would probably be kind of your typical hypovolemic shock. Some distractors for this call would be the blood pressure. As I mentioned, the blood pressure is normal for this guy. And so, if he's still in compensated shock, blood pressure isn't an accurate indicator that he's going into shock. And we want to be catching shock before the patient starts declining. And then, as mentioned earlier, he had a laceration to the knee. Yes, it is bleeding, and yes, we should probably deal with that, but it's not like a life threat. It's not something we need to, tend to right away. But this guy is suffering from probably some hypovolemic shock, and we should get RFD out here for him, especially with the decline in mental status. If we were to wait about, maybe 10 more minutes and refuse this guy, he might, have a drop in BP, have a drop in his condition, and end up in a much worse state if we were to refuse him. So case study 2, we're going to be looking at a little bit different of a situation here. We're dispatched to a maintenance building where a worker is having some difficulty breathing. And this is going to be a 52-year-old male, as opposed to our last patient who's pretty young. He can't catch his breath. He has general pain around the chest. The history of hypertension, no allergies, takes some medications. Maybe you know what those are, maybe you don't. Vital signs, heart rate is looking a little high, not as high as the last guy, but still up there. BP is looking a little on the low side, respirations are up again, and oxygenation is down. So is this a shock patient? It's kind of on the border here. We should definitely be concerned by a few things, and we'll have to think about what we want to do next, what else we should assess for. We've got pretty good medical history down so far. Because this came in as a difficulty breathing, we'll probably want to check breath sounds as soon as we can. See if this guy is wheezing, if he has crackles, if whatever is going on in there. And see if that can help us with our assessment at all. Other than that, we'll probably recheck vital signs and make sure they're more or less in the same area and that he's not deteriorating at all. And so we check sugar and temperature just to rule those out. Those are looking good. We end up checking lung sounds. We hear bilateral crackles, and we have skin condition as pale and clammy. Now, does this appear to be a shock patient? Well, pretty much everything is pointing that way. What kind of shock would it be? That's going to be probably cardiogenic shock. We've got chest pain. We've got a history, cardiac history. We've got crackles in both lungs. Heart rate's high, respiratory's high, and BP is looking a little low as well, and SpO2 is a little concerning also. So everything's not looking too good for this guy. He's probably on his way into decompensated shock. What we should do next is probably get RFD out here as soon as we can. Make sure, now that we've identified shock, that we can get this guy ALS care as soon as possible. Follow our traditional shock treatments, and maybe relook at this patient to be picked up by the ambulance a little sooner. So, as I mentioned earlier, our most important role is really going to be recognizing shock. It's going to come back on us pretty hard if we miss this, refuse somebody, and 15 minutes later they're lying unconscious somewhere. So it's really on us to recognize shock and understand all the different things we need to look for. Starting off here, we're going to look at the MOI or the NOI, kind of think to ourselves, like, is this capable of producing shock? consider the different types of shock and think, is this possible that this patient could be a shock patient? Because admittedly, there are some conditions where you're not even going to consider shock because there's no real suspicion for it. But after we do that, we'll look at the skin condition. Are they pale? Are they cool? Are they clammy? All these things should be indicators we should be looking out for shock. Vital signs, weak, rapid pulse, and increased respiratory rate, which we saw in pretty much both of our use studies up above. And then medical history, do they have any recent problems, like they've been sick recently, or do they have any long-term problems? In the case of the cardiac case, that may kind of provide some evidence for the NOI or MOI a little bit more. And then another one we need to look at is mental status, confusion, anxiety, restlessness, agitation. Don't kind of just, take these things for granted, like, oh, he got hit by a bike, of course he's going to be anxious. Kind of think a little deeper and think, could this have a medical cause rather than just us playing it off as natural? So UTD specific, we could have major or minor traumatic injuries capable of causing shock. Our motor vehicle accidents, we've had a number of those. Patients could either be, stable or in critical condition. It's really anything, and that could be definitely a major traumatic injury. Skateboard accidents, maybe the patient fell onto their head or had some sort of blunt impact, or maybe a sharp impact has a bleeding, a heavy laceration. Really, it could be, across a range of possibilities with that. Infection is another one, whether it's sepsis or some sort of hypovolemia from sickness. But really the point to all this is like shock is definitely possible at UTD. We've definitely come across it before, and it's really our responsibility to be the ones identifying what's going on. And so in closing, as I mentioned, shock can and does happen at UTD. We've done it, we've seen it before, we'll see it again, and it's not something that we can afford to miss. Pretty much every patient we suspect of having shock should be upgraded to an RFD call. As mentioned a few times, shock is a lot more than blood pressure. You shouldn't just be looking at blood pressure to determine shock. Mental status, skin condition, the rest of the vital signs are all very important in identifying shock. And then again, low BP is a late sign of shock. And if we're seeing low BP, we should definitely be thinking that the patient's condition is not looking too good. They're in the decompensated phase. And really, we want to be identifying the patients while they're still compensated. Before we have them sign a refusal, we need to be doing this. And we really can't afford to be having patients refused. They're actually suffering from shock. But that's about it. As always, remember that when seconds count, it's action time. And thank you all for joining us. I hope you learned something about shock.